Chapter 22, Abdominal Emergencies. This chapter is not going to be overly difficult. There's obviously a handful of conditions that can affect the patient within the abdomen, mostly dealing with various organs and Chapter 22, Abdominal Emergencies. So this chapter isn't going to be overly difficult. There's quite a few different things that can be going on within the abdomen, and it does require us to do a good comprehensive assessment. But at the end of the day, our treatment plan is going to be relatively the same. The important thing here is that we can quickly identify potential life-threatening issues, initiate rapid transport, or request the appropriate resources for our patient based on their presentation and what we think could be going on with them. So the anatomy of the abdomen, there's a whole lot going on, right? The abdomen technically includes everything below the diaphragm and above the pelvis. So within that, we have our digestive system. We have major components of our endocrine system. Our central nervous system is still included within that. So there's a lot of stuff going on there. And because of that, there's so many different systems, so many different organs. There's a lot of potential issues that patients run into there, most of which are associated with some type of pain. So within this chapter, we'll talk a lot about the different types of pain and how we can use that to try to clue us in as to what could be hurting, what would cause the pain, and most importantly, where it is coming from. So looking at this here, this kind of reemphasizes what I just said, right? We've got a bunch of different systems, a bunch of different organs. Everything is just jam-packed in there. Look at the small intestine. That small intestine is just crammed into the abdomen there. And as a matter of fact, when we get into trauma, we'll talk a lot about things like eviscerations, where the abdomen is cut open for whatever reason, and it allows the intestines to spill out because they're so compacted. As soon as they're given some room to expand, that's exactly what they do. So there are different organs within the abdomen. There's solid organs and hollow organs. And although for the purposes of the abdominal chapter here, those will present differently with pain, and we have some different issues we need to be concerned with. This is especially going to be important when we get into the trauma chapters. The solid organs are typically going to have a lot more blood within them. They are at greater risk for hemorrhage, but they also require additional force in order to be damaged. Whereas the hollow organs have a lot less blood, but they have still obviously very important things such as urine, bowel content, and everything else. And when any of those get injured or ruptured and that bacteria escapes out into the abdomen, now our patients become prone for sepsis and other infections. So we could bleed out or we could get sick and die, right? That's essentially the two differences when we are looking at trauma with those different organs. So a lot to consider here. Obviously, from an anatomy standpoint, these are all things that you should know by now. You should have reviewed those multiple times throughout the different chapters. If you don't know your abdominal anatomy yet, make sure you start working on that. So the abdomen is divided into 4 separate quadrants. We got the right upper, right lower, and left lower quadrants here. Now the belly button here, that's what actually divides top from bottom and left from right. And it's important to consider this. So as you're listening to this, find your belly button and think about, put your hand right where your diaphragm should be, right below that xiphoid process in your chest. And your upper abdomen or your upper quadrants are very, very small compared to your lower quadrants. The lower quadrants go all the way down into the pelvic girdle there and typically involve a lot more in the way of organs. Now the upper quadrants, those organs are going to usually be more life-threatening if there's an issue with them. But that doesn't mean that we can't have life-threatening issues in the lower quadrants as well. The other thing to keep in mind too, looking at this picture, is that some of your organs are actually protected by your rib cage. So if we go back a couple pictures here, right, we have some cross sections of our ribs, and you'll see here that the liver and the spleen both are somewhat protected by the ribs. So what that means is we can't use the rib cage itself as a determination as to whether or not something is in the thoracic or abdominal cavities. Looking at this, right, the diaphragm goes all the way up here and wraps around the top there. So it goes way up underneath that xiphoid process, and what happens is your abdominal contents go up underneath the bottom portions of your rib cage. So when we're palpating our patient and we're looking for different indications, physical indications of distress, we should be palpating way up into the rib cage there and even pressing slightly underneath the rib cage trying to find areas of rigidity, distension, or anything else. Okay, so now talking about the peritoneum. The peritoneum is a thin membrane, it's a lining, if you will. And you have two separate types of peritoneum within the abdomen. You've got the parietal peritoneum, which covers the entire abdominal cavity, right? It's pretty much attached to the backside of the abdominal wall. And then you also have the visceral peritoneum, and that surrounds each individual organ. So when you think about it, it's kind of like buying produce at the grocery store. If I were to take one of the produce bags and place a single, let's say a cantaloupe, right? I place a cantaloupe inside one of those produce bags. That produce bag is the visceral peritoneum surrounding that one organ. And then if I take that and I place it along with other items inside of a normal shopping bag when I go to the checkout register, then that's going to be representative of the parietal peritoneum. So visceral surrounds each individual organ. Parietal surrounds the entire cavity and includes all of the organs within that area. Now, that being said, there are a few things that don't fall within the parietal peritoneum. Okay, we have things that are considered extra or retroperitoneal. And in those situations there, right, extraperitoneal simply means outside of the peritoneum. So it's not within that overall abdominal sac. But we have a few things that sit retroperitoneal, meaning behind the peritoneal sac. And that would include things like the kidneys and the pancreas and even part of the aorta. Now, the reason that that's important to understand is because those organs there, when they are infected, when they are injured, whatever, the pain will typically be felt more in the back than it will in the front. So it makes sense that things that are retroperitoneal or behind the peritoneum toward the posterior aspect of the body, those things would be felt in the back. Whereas everything else that sit within the parietal peritoneum will most likely present with pain toward the front of the body. We also have the bladder and part of the rectum that lie inferior to that. You're still going to feel pain or discomfort in the same regions that those would be located, obviously with the bladder toward the front and with the rectum toward the rear then. So looking at this picture here, right, this is a great cross section of kind of everything that's jam packed in there, and it is a full area without a doubt. Looking at this here, you see the highlighted area now. So that is everything that is within the parietal peritoneum. This is that abdominal sac. Okay, everything that you see grouped in here would most likely present with pain toward the front of the body, and then everything else that kind of sits retroperitoneal would be felt with pain toward the back of the body. So that includes things like your abdominal aorta here. We'll talk in a few minutes about a AAA, or an abdominal aortic aneurysm. And that's when the aorta itself can rupture or split. And when that happens, people typically complain of a sharp tearing pain, and that tearing pain is felt in the back, usually indicative of some type of rupture or hole in the abdominal aorta. So talking about pain, there's several different types of pain or descriptors that may be used by patients. Visceral pain is something that originates obviously from within the visceral peritoneum, and that's going to be around each individual organ. Now, because these individual bags, if you will, are not nerve heavy, right? They're actually kind of sparse as far as nerve endings go. The pain is not easily located. So if I have something that is wrong with we'll say my kidney, for instance, right? Rather than being able to point to a very specific spot on my body, I would probably describe it as being relatively diffuse, dull, or achy. The same thing can apply if I have anything going on, whether it be within or outside of the peritoneal sac, it doesn't matter. If it's having to do with an individual organ, it's probably going to be a more diffuse pain. It's going to be generalized. I'm going to say, it's more within this region than anything else, and my descriptors will be relatively broad. Sometimes you'll hear people describe things as being colicky, meaning intermittent. And I'll tell you, the thing about colicky pain here, one of the probably the more common presentations is going to be in the form of gas. And I'm sure we've all had it, right? Some type of abdominal discomfort secondary to having a gas buildup. Maybe you ate something that didn't agree with you, whatever the case may be. But when you have that sharp intermittent pain, depending on where the gas is, as the gas tries to move through the digestive system, that would be an example of a colicky pain, right? It's sharp, and it's very very uncomfortable, and again, it's intermittent. Now, when we have pain that is constant, that's more than likely going to be originating from a solid organ, right? Because we don't have things necessarily passing through solid organs. Everything is fixed, it's stationary, and that's why we can usually try to use that as a differentiation. Now, parietal pain coming from that overall abdominal sac, that's going to be very pinpoint. A lot of times it'll be described as sharp, and what that means is that the patient could probably take one single finger and point exactly in their abdomen to where it hurts and say, it's right here, it's this little tiny spot, this is where it's at. And the reason being is the parietal peritoneum is very rich in nerve endings. Therefore, it's very easy to pinpoint the location of the pain because we have so many nerve endings. And the other reason, too, is because it's obviously right there at the surface of the body, right? It's not pain originating from an organ that's kind of set deep within. This is right here at the surface. And this could be a result of multiple different types of issues, right? We could have basic inflammation, peritonitis. If somebody has a hernia, these could all play into it, and we'd be able to, again, localize specifically this is where the pain is at. The tearing pain is what I referenced when I talked about the abdominal aneurysm. That's probably going to be the most common presentation of a tearing pain. Now, with these patients, if we have a patient that is complaining of a tearing pain, we've already spent too much time on scene, right? If the patient is still alive when we get to them after having an abdominal aortic aneurysm, then they've already won the lotto, and let's not push their luck anymore, okay? We need to hurry up and get them to the hospital. Depending on the size of the aneurysm, it's potential for them to bleed out within less than a minute. Now, if it's a smaller aneurysm and it's a slower bleed, then that's great. Let's recognize that immediately and initiate that rapid transport. There's nothing that you can do or I can do as a paramedic. This is strictly a surgical intervention. That's it. So don't waste time calling for ALS or anything else. You should just strictly be driving to the closest facility you can that's capable of providing surgical intervention. Now, referred pain. Referred pain is unique, right? We've talked a lot in the past, especially with the cardiac chapters, about stuff having to do with radiating pain, right? Pain that originates in one spot and then it travels somewhere else. And we'll talk about that as well within the abdominal chapter here when it comes to things like um, kidney stones or appendicitis and stuff like that. But referred pain now, that's different. Referred means that something is bothering, right? The pain is felt somewhere other than where the actual organ is affected. And I'll give you an example. In a rollover car accident, a woman complains of left shoulder pain. Now, upon assessment, right, even a rapid head to toe assessment, the patient was not, they didn't discover any injuries on the patient whatsoever. Okay. Her only complaint was to the left shoulder. They evaluated her. They looked at the left shoulder. She had full range of motion. SMVs were intact. No bruising, no signs of trauma, no nothing, right? And it's simple that, you bump your shoulder and you're just sore, not the end of the world. So despite a good comprehensive assessment, the patient said, you know what, I think I'm fine. I don't want to go to the hospital. And the EMS crew didn't really push it all that much. Yes, the mechanism of injury was there, but after a good comprehensive assessment, there were no other issues found, right? Do we really need to force patients to go to the hospital if we can't find anything wrong with them? Well, that's a good question, because that patient ended up dying later that evening because of a splenic rupture. So the spleen, located in the left upper quadrant, because that was lacerated as a result of the rollover accident, the pain itself was felt in the left shoulder. Now, there were two things that contributed to this. One, the fact that referred pain just simply exists in either of the upper quadrants, right, where it refers up to the associated shoulder. And two, because this was an elderly patient, her pain reception capabilities were diminished, right? Her body just wasn't able to sense things as accurately as it used to. So because of these two things, right, they didn't pick up on the splenic rupture. There was no physical findings that would have suggested that there was any type of splenic injury, and as a result, the patient ended up dying. Now, this was to no fault of anybody else. The only lesson that can be learned here is simply that when the mechanism of injury exists, it's important that we strongly recommend to the patient that they be transported for further evaluation, only because we have the possibility of those hidden internal injuries that cannot be identified with an external exam, right? Being able to go in for an MRI or a CT or X-ray or any other imaging technologies is going to help us to identify some of those hidden injuries. So now we're going to get into some specific abdominal issues, appendicitis being one of them. Come in, bud. So we'll begin with appendicitis. Appendicitis, if we look at the word, is pretty easy to decipher, right? Itis meaning inflammation of, typically associated with infection. So this is inflammation or infection of the appendix. Signs and symptoms of this, I'll tell you, I used to teach this very matter of fact. I used to say, okay, here's your signs and symptoms, here's what you need to look for, and if the patient presents with these things, then bam, you got appendicitis. And that was the case until I had a personal experience with this, not with me, but with a buddy of mine. And we met at the fire station one morning. We were going to go to a conference together, and he got in the truck and he said, oh man, I've got this terrible back pain today. And I said, really? He's like, yeah, I've been starting a new workout routine and just really worked the lower back, and I think I maybe stressed it a little bit. You know, that happens. So anyways, we start driving. He's like, yeah, and I think there was even some blood in my urine this morning. And I'm like, well, that's probably not part of a lower back thing. That's got to be something else. I said, what else is bothering you? He's like, I don't know. It's just a little discomfort when I urinate and some blood in there. And I said, well, is it possible that you could have a UTI or something like that? He's like, yeah, I don't know. So he's obviously discomfort in the truck as we're driving down to this conference. And I asked him, I said, are you sure you want to go? Do you want to turn around? And he said, no, I'll be fine. So we get to the conference anyway, and throughout the day, he's getting more and more uncomfortable. And about noontime, at lunch break, he says to me, yeah, this is really bad. I think I'm going to have to go early. Now, obviously, he rode with me. And I said, okay, well, right after lunch is a presentation that I really want to see. Do you mind if we wait until after that? And then we can head home. He's like, yeah, no problem. So we did, and I think we probably got on the road maybe around 2 o'clock or so. And driving home then, there was a butcher shop on the way home that isn't close to the house, but it was on our way, and it's a really good butcher shop. So I said, hey, I told Stacy that I'd stop and grab dinner. Do you mind if I swing in and grab some food really quick? He said, yeah, that's fine. Meanwhile, he's fidgeting in the front seat. And so anyways, I go in there, and there's a line. It's a popular butcher shop, so I'll wait in line for a little while, get my food, jump in there, and eventually we get back to the fire station. I drop him off at his car, and he says, yeah, I'm going to go in and get checked out at the hospital, I think. So less than an hour later, he sends me a text message saying that he's going in for emergency surgery for his appendix and that it's about ready to burst. Naturally, I felt pretty bad at the time. I laugh at it now, but at the time, thinking, look at all these delays, right? Not only did we go to this conference, but then I told him after lunch that, hey, let's just wait a little bit longer. And then we stopped and took time for me to grab, dinner for my family on the way home. These were all things that could have gone really bad. Now, the problem was he didn't present with any of the signs and symptoms on this slide. He presented entirely different. He only had lower back pain. It didn't radiate anywhere. And then the only other thing that he had that could have clued us in was the blood in the urine. But there's 100 different things that can cause blood in the urine, a UTI probably being one of them. So it was easy to miss, right? And that's going to happen. That is most certainly going to happen. But nonetheless, we should know some of the more common presentations here. And if a patient is presenting with these, be able to clue into the potential for appendicitis. And even just simply ask them if they've had their appendix out in the past. And if they say, yeah, they've had the appendectomy, then most likely, it's not going to be appendicitis, right? So we can move on and try to come up with some other cause for their presentation. But back to the slide, talking about appendicitis individually, we could have some nausea and vomiting, and that's typically more associated just with the pain and discomfort more so than anything else. But the location of the pain. So it says initially referred to the umbilical region, meaning that they can begin to feel pain in and around their belly button, and then eventually it may end up becoming more persistent in the right lower quadrant, and that's as the inflammation or the infection continues to expand. In the event that they rupture their appendix, right, we would expect a sudden severe increase in pain. So we're talking about a patient who's complaining of pain that's maybe a 5 or 6 out of 10, and then all of a sudden it's a straight 10 out of 10. They're keeled over, they're in that fetal position, they're rocking back and forth, incredibly uncomfortable. These are all things that we would expect to see once the appendix itself ruptures. Now, from our perspective, there's not much we can do for a ruptured appendix, right? If the appendix does rupture, it's going to be a surgical intervention, IV antibiotics, and they're just going to try to address the infection that could potentially ensue. And the appendix itself, that's what the purpose is. The appendix holds bacteria. And they've actually found out recently, right, and I'm sure that a handful of people listening to this have had their appendix out, but they found out recently through some studies that although the appendix can be removed and the people can still function without it, it does serve an important purpose. And that is that it holds good bacteria. And that good bacteria reservoir allows it to release that bacteria into the abdomen, which can be used for different digestive purposes and even immunological purposes. So moving on then to peritonitis, looking at that, inflammation of the peritoneum. Again, a lot of times this is going to be a result of some type of infection. It could also be a result of some type of tear within the peritoneum, such as with a hernia or something else. It could be a result of, it says here, acidic substances. So heartburn could present, let me rephrase that, peritonitis could present as a heartburn from time to time. So any number of things that can go on. Now, the thing about peritonitis here, right, is we're going to have that very localized, sharp abdominal pain because it has to do with the peritoneum, and we could have rigidity. Anytime something comes in contact with the parietal peritoneum, the sac that lines the entire abdomen, it immediately becomes very tense and hard. And as we palpate it, that rigidity is going to seem more like there's a rock underneath the surface of the skin than anything else. And when we feel that rigidity, that should be an indication to us, okay, we have some type of peritonitis going on. Now, peritonitis, I don't want to stop there and say, oh, this is probably peritonitis, let's just go to the hospital. I want to look deeper. What's causing this peritonitis? Is it something simple like a hernia, or do they have a bowel rupture that is causing this infection of the peritoneum? Because something like that's going to be a lot more significant. Now, granted, there's very little that we can do pre-hospital for abdominal issues, right? Anything internal, very, very little we can do. But immediately recognizing it and getting them to the hospital is important. And then we're still going to have to try to treat signs and symptoms. So when it comes to abdominal issues here, yes, as a paramedic, I can't do anything more for peritonitis than you can as an EMT. The only thing I can do is treat some of the symptoms a little bit more. So I could administer narcotic pain medication to address the issues that would come along with this. If they are nauseous from the pain or discomfort, while you can give Zofran PO, I can give Zofran IV. A little bit more potent that way, and obviously if they are actively vomiting, then I can give it IV, whereas we wouldn't be able to give the medication PO. Cholecystitis or gallstones is a buildup of stones that are produced in the gallbladder. They block the little bile ducts that go from the gallbladder into the stomach. And the gallbladder, if you remember, its primary function is to produce acids or biles that help to break down the different fats. So when people eat fatty foods, the gallbladder goes into overtime, and it produces additional bile to begin to break down all that fat. When those bile ducts get clogged up, that's a result of the gallstones, and people become very uncomfortable with that. A lot of pain, a lot of discomfort. And in this situation here, obviously, we would be looking for right upper quadrant or epigastric pain, right? Meaning that it's up at the top of the stomach. And it would typically follow eating, especially if they were eating fatty foods. Okay, those are things that we would expect to see. Because it's in the right upper quadrant, we talked earlier about referred pain. Anything that's in either of the upper quadrants could in fact be referred up to the shoulder, meaning that even though they only have pain in the shoulder, the problem itself may exist down in the abdomen. Pancreatitis, inflammation of the pancreas, so typically having to do with some type of infection or alcohol abuse. And in that case there again, epigastric pain. It's just going to be pain localized to the location of the pancreas itself, and it could be referred to the back or shoulder just because of where it's positioned. Now keep in mind with this also that if the pancreas is infected, if it's not working properly, even though the patient may not have a diabetes diagnosis, they could still have issues with insulin or glucagon production or other hormonal imbalances. So as a result of that, if they are presenting with this pain, we should still be checking their sugars, making sure everything seems okay, and watching for overall signs of poor perfusion. Looking at the GI potential for bleeding, we're going to obviously not only have patients that present with any pain or discomfort, but now we're going to have some external clues. If they have any blood in their bowel or in their vomit, those are going to be the biggest indications. And remember that with GI bleeding, we can have upper or lower, right? If it originates up above the GI tract or above the intestinal areas, it's going to be considered an upper GI bleed. And if it's lower within the intestinal areas, it's going to be considered lower GI bleed. Both are potentially life-threatening, especially if they go unaddressed. And more importantly, they can typically indicate a much larger problem, such as rectal bleeding, right? If patient has blood in their stool, that alone could indicate something as simple as hemorrhoids, right, which can be treated, non-life-threatening in most circumstances, or it could indicate something like colon cancer. So these are never things that we should, put off or ignore. Anytime we have blood coming from an orifice of our body, it warrants being checked out. At a minimum, going to the doctor, if not, going to the emergency room if necessary. And the thing here is, although a lot of times it will be associated with pain, from time to time it may be painless, such as is the case with maybe a rectal bleed secondary to colon cancer or something like that. So lots of different things that can come from this. When we are evaluating our patient, we're looking for either dark or bright colored blood coming from either the mouth or the esophagus versus coming from the rectum or the back end there. When it's a bright colored blood, that means that the bleeding is originating close to the source that the bleeding is exiting the body. So if I have a bright red blood in my vomit, then that would typically indicate that it's going to be an upper GI bleed, that the source of the bleeding is close to the upper part of the GI tract there. And that could be an example of something like an esophageal varices. Now I'll give you an example of a situation I had with esophageal varices. We were dispatched for a 16-year-old kid who was vomiting blood. And we arrived on scene, and it was, I think, a Friday or Saturday night. Kid standing at the front door of his home with his mom. And I'm thinking to myself, okay, based on the demographic, the time of day, everything else, this kid probably maybe had something to drink, a little alcohol. He's sick, he's vomiting. Something he drank was red and fruity because that's what 16-year-olds like to do, and not a big deal. Long story short, we walk in, talk for a minute, walk out to the ambulance. Mom's riding along with us, and she says to me that her son had cancer as a child and had radiation treatments for the treatment. And the radiation had caused esophageal varices to develop in her son. So, okay, this makes sense now. Now I understand. But the kid is still awake. He's alert. He's oriented. He's talking and walking. So I'm not really very concerned about this patient. Jump in the back of the ambulance. My partner starts driving. I'm doing basic set of vitals. No big deal. All of a sudden, the kid says he feels like he's going to vomit. So I hand him a nemesis bag, and he leans forward and he vomits. And he filled that emesis bag with bright red blood. Now, for perspective, those emesis bags are about 1,000 milliliters. So roughly 20% of his circulating blood volume. Now, if you remember from the shock and perfusion chapter, once a patient loses about 20% of their circulating blood volume, they are in a shocky state. Now, I asked Mom, I said, is this what his vomit looked like at home? And she said, yeah. I said, how much did he vomit at home? And she said, well, he filled a good part of the toilet with it. There was quite a bit. And as we're talking about this, and I'm struggling to kind of get an IV started and everything, I'm watching the color drain out of this kid's face. I mean, right in front of me, this kid is actively hemorrhaging internally. I'm watching as his blood vessels are constricting, as the sympathetic response kicks in, right? Blood vessels constrict peripherally, trying to shunt what little blood he has left in toward the core of his body. He's becoming pale. His mental status is decreasing as his blood pressure drops. He's no longer perfusing the brain adequately. So now he's semi-conscious on me. I mean, I'm watching this kid crash right in front of me. Needless to say, I yell up to my partner to step on it. I'm struggling to get an IV. I'm enlisting the help of Mom. I don't even have time to stop and wait for additional resources, right? This kid isn't going to make it if we delay anything. So I'm trying to get an IV started, trying to pump this kid back full of fluids, get his perfusion up. I mean, this kid crashed right in front of me, all from esophageal varices. So when we talk about GI bleeding, a lot of times it's something simple. Oh yeah, I noticed a little bit of blood here or there, or it can be something pretty profound, such as that example. So always be aware of these things. Have that heightened sense of awareness and be ready to act quickly, and never write these off. Never be complacent with the basic GI bleed. Okay. As opposed to the bright red blood in the vomit, we could also have coffee ground emesis. And what that is that's a sign of a lower GI bleed, but for whatever reason, the patient is vomiting that partially digested blood. Okay. And in those situations, we have a lot of concerns, right? Not only the bleeding, but why is it that if it's a lower GI bleed, why is it that the patient is vomiting that up? So those are things that we should be thinking about. And then looking at the back end, if they have a bright red blood in their stool, it's probably going to be a lower GI bleed, something within the colon itself, and a lot of times indicative of things like we mentioned earlier, the hemorrhoids or colon cancers or any other things. However, more often than not, patients will complain of a dark tarry stool, so very kind of thick and sticky, but not solid, and that's going to be indicative of an upper GI bleed. And then that blood is partially digested within the rest of the bowel content mixed in there, and that's what gives it that black tarry effect. Abdominal aortic aneurysms we mentioned earlier. That's a sudden weakening and tearing in the abdominal wall. A lot of times, patients that have chronic high blood pressure can be predisposed with this, but there's other conditions that can affect it too. Nonetheless, the patient's going to complain of a sudden onset of a sharp or tearing sensation, and a lot of times it's going to be attributed to their back, just because of where the abdominal aorta sits. With these, the patient can die within a matter of minutes, or if it's a smaller tear, they may have a slightly additional or a few additional minutes to get to the hospital and get that surgery done. In these situations here, it is possible that we can palpate and feel a pulsating mass deep within the abdomen, but more than likely we're not going to be able to feel it because of its location and because of how the spinal column itself kind of protects the aorta. So if the patient's complaining of a sharp tearing pain in their abdomen, again, you're already on scene too long. You should be rapidly going to the hospital and making sure that you contact the hospital as soon as possible to give them that warning and allow them to be prepared for the patient and have a surgery table ready to go. Okay, moving on to hernia then. Hernias happen. I'm sure a lot of you have had a hernia in the past. Not the end of the world, but they can be very painful, as you can imagine. Because the hernia typically involves a parietal peritoneum, it's going to have that very sharp pinpoint pain, and the patient may be able to tell you exactly where it's at. A lot of times it is going to require surgical repair, so not much we can do for any of these conditions other than identify. We'll treat the patient, make sure that we transport in a condition of comfort or in a position of comfort, and then monitor the ABCs as necessary. Okay. Renal colic, these are actually your kidney stones. And in those situations there, you have buildups. A lot of times it has to do with calcium. You have these calcium buildups within the abdomen. The calcium binds together, forming small little stones, and then those stones are lodged within the kidney itself. And the pain comes when those stones try to pass from the kidneys down through the ureters toward the bladder. And then if they're small enough to get through the ureters and into the bladder, the pain especially is apparent when the patient tries to pass those as the stone tries to enter into the urethra and exit the body. With these patients, obviously, we have radiating pain that can originate all the way up in the flank by the kidneys, radiating down toward the bladder, and then even out through either the vagina or the penis, depending on the gender of your patient. Within those two, they could complain of a burning sensation or even blood in their urine. These patients, again, not much we can do but transport, but I'll tell you, they are in terrible pain. Some of the most painful situations that people will ever experience in their life. So at a bare minimum, really be sympathetic, get them to the hospital as soon as possible. And although, as a paramedic, I can't treat the kidney stone, I can treat the pain. So never hesitate to request ALS if it's available to you. and allow them to administer the pain medications to help make these patients a little bit more comfortable. Here's the other challenge. With everything we just talked about, it's cardiac until proven otherwise. And I say that slightly facetiously because, with cardiac pain, with heart attacks, it can originate within the chest, and it can radiate down into the abdomen. Or some patients will only feel pain or discomfort in the abdomen, and that makes it really challenging, right? These patients, we always have to assume that things could potentially be cardiac in nature. So even if we have a very strong differential diagnosis that it's going to be an abdominal issue, we must also consider that it could potentially be cardiac. Okay, assessment and care of the abdominal pain patient. I'm gonna skip through a lot of this. As a matter of fact, your assessment is sample OPQRST like it always is. Your scene size up, primary and secondary assessments are all the same. There's only a couple of very small changes that you might include in here. When we're talking to female patients, asking things specific to pregnancy or their menstrual cycles may be appropriate depending on the location of the bleed. We'll talk about that stuff more in class. With our geriatric patients, because they have a decreased ability to sense pain, a lot of times things can be going on that they aren't able to describe to us or that we're not picking up on. So those are things we have to really watch. Additionally, because our geriatric patients a lot of times are on blood pressure medications and other meds like blood thinners, it may be very difficult for them to compensate when there is something going on within the abdomen. As we're assessing the abdomen, the ability to touch the patient is probably most important, right? We're not going to be able to visually look at the patient and see abdominal issues. We need to actually touch. And as we palpate, we're not just touching 4 little spots within the abdomen. We're rolling our hands across the abdomen. We're palpating every square inch, trying to identify any areas of pain or discomfort, looking for rigidity or distension, and other things like that. Now, again, these are all things that we'll practice in class quite a bit. Really quick, talking about the term guarding. We've talked about that in previous chapters. Guarding is simply where the patient naturally tries to protect an area of discomfort. So if a patient presents to you and they are covering their abdomen, obviously that tells you, one, that there's an abdominal issue, but try to look at the area that they're naturally guarding or protecting. And that's probably going to clue you in as to where that pain is originating from. Vital signs are important. With stable patients, yeah, we're doing vital signs every 15 minutes. But even then, it should probably be more frequently than that. And with unstable patients, certainly every 5 minutes, but even really more often. We are constantly assessing our unstable patients, monitoring things like blood pressure. We're keeping an eye on the pulse rate, nonstop. We're watching for changes in their skin parameters, all that stuff. When we're dealing with the general abdominal distress, and a lot of times we're not going to be able to pinpoint exactly what it is. As a matter of fact, you will never be able to definitively diagnose any type of abdominal emergency. We're just going to have ideas as to what it might be. Generally speaking here, you treat the signs and symptoms, right? If they're having airway issues or difficulty breathing or anything else, we treat all those things. If they're showing signs of shock, we keep them warm, we administer oxygen. All we're doing here is simply treating signs and symptoms because we can't really get to the root causes. And those are really the big things for chapter 22 here. It's a tough chapter because there's a lot of abdominal things that can go on. You should know the primary signs and symptoms of all those different abdominal emergencies that may present. You definitely need to be able to differentiate between the types of pain, visceral pain, parietal pain, referred pain. We need to understand how hollow organs will present differently than solid organs. We need to know the differences between presentation locations of things that are within the peritoneum compared to extra or retroperitoneal. So all of those things are all subjects that you'll be tested on both in class and on the exams themselves. As always, if you have any questions, reach out to any one of your instructors. Thank you for your time and enjoy the rest of your day.